So what happens when an imaging scan, maybe for something totally unrelated, suddenly shows a cyst on your pancreas? It definitely sounds alarming, but you know what? It's a surprisingly common thing to find. So let's dive into this diagnostic mystery together and figure out what it all really means.
Right, so what does a cyst on the pancreas really mean? This is a huge question because honestly, the answer can be anything from completely harmless to a very serious warning sign. To get to the bottom of it, doctors basically have to become detectives, looking for some very, very specific clues.
Okay, before we get into the real suspects in our mystery, we have to talk about the most common culprit, which is actually a bit of an imposter, the pseudocyst. And just like the name says, it's not a true cyst. It's usually just a pocket of fluid that shows up after someone's had pancreatitis. And while it is by far the most frequent thing we see, it's not the focus of our investigation today. We're on the hunt for the true cysts. All right, let's meet our first major suspect. In the medical world, it's called a serous cystadenoma. But to make it really easy to remember, we're just going to call this one the grandma cyst. And here is the genius little phrase that'll help you remember everything about her. Grandma Serous is the head of the household. It sounds simple, right? But this one little mnemonic is brilliant because it packs in almost all the clues a radiologist needs to make the right call. So let's break down Grandma's profile, shall we? First, the patient is usually an elderly lady. That's the grandma part. Now, the best news about this one, it's benign. It's not cancerous. And where does she live? Well, she's the head of the household, so about 70% of the time you'll find the cyst in the head of the pancreas. It has this kind of sponge-like look, and in about 1 out of 5 cases, you'll see this classic telltale sign, a central scar. And this is really important. It does not connect to the main pancreatic duct.
Okay, time for our second suspect, and this one has a very, very different profile. This is the Mucinous cystadenoma, and you guessed it, we're going to be calling this one the mother cyst.
And the mnemonic here is just as simple and just as powerful, mucinous in the mother. And as you're about to see, this particular character has totally different and much more serious implications for a patient's health.
Let's look at the clues for the mother cyst. The patient profile is super specific. It's found almost exclusively in women, usually around their 50s. But here is the absolute crucial difference. This cyst is premalignant. What does that mean? It means it has the potential to turn into cancer, so every single one has to be surgically removed. And unlike grandma, this cyst likes to hang out in the body and tail of the pancreas. It's usually just a single cavity, and sometimes you'll see little calcifications on its outer edge. And just like the grandma cyst, this one also doesn't connect with the pancreatic ducts.
So let's put them side by side. This is it. This is the critical moment in the investigation. On one hand, you have the harmless grandma cyst, usually found in the head of the pancreas. On the other, the premalignant mother cyst, found in the body or tail. Being able to tell these two apart based on location, age, and appearance, that literally changes a patient's entire treatment plan from, we'll just keep an eye on it, to we need to schedule surgery. But wait, our mystery is not over yet. There's another character, a much more complex one, that actually comes from the pancreatic duct system itself. This one is called an IPMN, and with this guy, everything, and I mean everything, depends on which path it decides to take. It's like a fork in the road, or, in this case, a fork in the duct. So, IPMN stands for intraductal papillary mucinous neoplasm. Yeah, that's a mouthful, I know. But don't worry about the name. The only word you need to remember is intraductal. See, unlike our last two suspects, this tumor actually grows from the lining of the ducts, and it produces this thick, gooey fluid called mucin. And this is exactly where that fork in the road comes into play. If the IPMN is growing in a small side branch off the main duct, it's actually pretty common and often benign. The usual approach is just observation. But if it involves the main pancreatic duct, the whole story changes. Main branch IPMNs are all considered malignant, and surgery is pretty much always the next step. It's a massive difference in outcome, and it's based entirely on location. So what are the big red flags that tell a doctor this is a high-risk main branch IPMN? Well, they're looking for specific signs on an MRI or a CT scan. A main duct that's wider than 10 millimeters, that's a big one. Or if it's in multiple spots, or if there are these little enhancing nodules inside, or if they can actually see a solid mass. These are the clues that scream, it's time to act.
And just to make things even trickier, there is one last character we need to add to our lineup. Now, this one can look just like a scary tumor on a scan, but it's not a tumor at all. Meet the inflammation imposter, autoimmune pancreatitis.
To remember the absolute key to diagnosing this condition, we've got a little chant.
It's super simple. I'll start. I say autoimmune pancreatitis. You say IgG4? That's it. IgG4 is a substance in the blood, and it is sky high in this condition. It is the single most important clue to telling it apart from pancreatic cancer.
And this just shows you how different this condition is. Besides those high IgG4 levels, patients often don't even have the usual painful symptoms of a pancreatitis attack. And the best part, it responds incredibly well to steroids, not surgery. On a scan, the pancreas can look all swollen and kind of sausage-shaped. So something that looks for all the world like a tumor can actually be an inflammatory issue that you can treat with medicine. It's incredible. So there you have it. From the benign grandma to the pre-malignant mother, from that critical fork in the duct with IPMN all the way to the inflammatory imposter, you can see how identifying a pancreatic cyst is a total masterclass in detective work. Knowing the difference isn't just some academic exercise, it is the absolute critical first step in a real person's journey. It really makes you wonder, doesn't it? What other diagnostic mysteries in medicine depend entirely on being able to see the